Okay. So this lecture is meant to be just a quick uh, down and dirty lecture on the physiology of blood pressure regulation and the physiology of the cardiovascular system, which will be really important when we start talking about the adrenergic antagonist and agonist that we'll talk about, which has its main effects in the cardiovascular system. So let's use this diagram, which kind of looks like a circuit, right? Remember from physics, we have a circuit. You can think of the cardiovascular system as a closed circuit, and where it branches off in the systemic circulation after the left heart, in the systemic circulation, and it branches to the heart, the brain, the kidney. You can think of all of this as kind of being in parallel. And then everything collects back up into the venous system, goes back to the right heart, and then to the lungs to be oxygenated, and then back to the left heart. So you can think of this. All right, Finn, I gotta take that. You can think of this yellow area as being, inside the chest. Does anybody know how much blood we have in the body? Well, it's around 5 liters or so of blood. And it always has to be recycled because of this closed system. So we have 2 pumps to move the blood, the left heart and the right heart. And the left cycles the blood through the systemic circulation, and the right heart cycles the blood essentially through the lungs to the left heart. So how do we get this movement, let's say, of clockwise of blood flow, right? Because if our blood didn't flow, it would clot and we would be dead very quickly. So what gets our blood to flow? Well, it's pressure differences, right? It's more pressure on one side versus the other, which pushes the blood in a certain direction, right? And we call this blood pressure. So if you look here, blood pressure right after it exits the left heart is around 120. This is essentially the number we use when we have our blood pressure cuffs at the physician assistant's office, and we get our blood pressure taken. But as the blood moves through and gets to its various organs, it drops pretty significantly to 40. We're not measuring blood pressure at the level of the kidney. Remember, we're measuring it at the arms, or right where the blood pressure is, or the highest. But what happens is once the blood starts branching off into other organs like the heart, liver, and kidney, it will drop significantly more. Think about blowing 5 liters of liquid through a straw and then 5 liters of liquid through a garden hose. It's going to be a lot easier to blow through a garden hose than a straw because you don't have to have as much pressure. Well, the same thing here. We can think of the main artery as a straw, and we can think of the branching or the parallel activity here as a garden hose. So the pressure is going to significantly drop when it goes to various organs. So we need this pressure, right? We need to have some sort of pressure, right, to get the blood to move forward. If I get in my car and there's a tire pressure gauge light on, well, I know that my tires don't have enough pressure. So what do, I add more air to get more pressure. So you can see here that after it exits the capillaries and venules, our pressure is only about 7 millimeters of mercury, which eventually gets pretty much down to 0 once it gets to the right heart. And then the right heart adds pressure back to it, from squeezing and its pump-like activity, to increase it to about 25, and then push it through the lungs where it will reach the left heart again. And it's all a closed circuit, right? So the pressures are different across the entire body. So when if someone is asking what your blood pressure is, it's the one here. And we're talking essentially arterial pressure, right? And we get 2 numbers when we get arterial pressure, right? We get the 120, but we get a diastolic pressure as well. So systolic pressure has to do when the heart is contracting and the pressure gets to its highest. And the diastolic pressure is when the heart relaxes and that residual pressure starts to decrease here, and the lowest that gets, 120 over 80. The pulse pressure is the difference between the systolic and the diastolic blood pressure. So those who have a wide pulse pressure versus a low pulse pressure, which you'll learn in clinical medicine, I'm sure. So how does our body keep blood pressure, right? I mean, there's so many pressures here going on. What if we need more pressure at the brain right now? Well, what if we need more pressure here and there? Things like that. Well, our body does this through various baroreceptors. Baroreceptors located right after the heart, or right after the left heart, and the aorta, the veins, the atria of the heart, the carotid sinus, the kidney, and the brain. That's how we monitor the pressures at the different areas, and how our body, through sympathetic input, can vasoconstrict or vasodilate specific areas to regulate blood pressure, right? So if you look here, the veins were drawn a little bit bigger than the arterial side. And why is that? And you can see this gradient here has more of the deoxygenated blood, which means more venous. Well, why was it drawn like that? Well, it's only about 17% of the total body blood volume is in the arteries, and 66% of the blood volume is in the venous system, with over 17% of it being in the chest, meaning between the left and right heart, going through the lungs to become oxygenated. So that's important to know when we talk about preload and afterload and things like that. So it's good to know that most of the blood volume is in the venous system. So it's kind of the same as a car, if you were to think about it. If you were to pump more blood into the body, okay, if you were to just put somebody on an IV, give them blood products, is their blood pressure going to go up? Not necessarily, no. But the venous pressure will go up, not the blood pressure that we think of as an arterial pressure. So not necessarily would the blood pressure that we measure in the arterioles or the arteries go up, but the pressure in the venous system would increase, okay? Because most of the blood volume is going to be in the venous system. So it's a good idea to think of the arteries as the arteries being the driving pressure. It's going to drive the blood forward. So the artery pressure is good to tell you the driving pressure across the organs, and the venous pressure is good to tell you the blood volume in general. And the brain also has its own baroreceptor because, of course, it thinks it's the most important organ in the body, so it gets its own VIP treatment baroreceptor. And if you think about it, our bodies are constantly fighting gravity, right? Gravity is always pulling things down, and our brain, and oddly enough, right, is at the very tip top of our head above our heart. So it needs its own baroreceptor to regulate blood pressure through the brain. I mean, if your blood pressure in the brain goes down even for 3 seconds, you'll end up on the floor. And then the kidney has its own baroreceptor as well, because it essentially controls blood volume by increasing sodium and water reabsorption. So it's interesting to think about this because this is a closed circuit, right? Because everything is in one single circuit, but everything has way different pressures, right? The blood pumped out of the left side has to be equal to the blood pumped out of the right side. Think about that for a second. Let's say, essentially flow has to be equal or the same everywhere. What if it isn't, right? That seems like it would be next to impossible to do. I mean, look, we're throwing out 120 pressure here, only 25 pressure here. There's 0 pressure here. How is it that the left heart and the right heart are pumping exactly the same amounts of fluid out of each stroke volume equally all the time for your entire life, right? To keep the same flow everywhere. That's very interesting, right? So the cardiac output, okay, you'll see here that the cardiac output, which is the output of either side of the heart, they have to be the same on both sides. But what is that equal to, right? What is that equal to? It's equal to the heart rate. So I don't know, like 70 beats per minute, right? It's equal to the heart rate, which is easy to measure, right? We look at our Apple Watch or we look at our Fitbit and we can get that right away. 70 beats per minute, I think, is what mine is right now. It's a little bit higher because I'm stressed out about doing this lecture. But let's say that. Does anybody know what a normal stroke volume is? A normal stroke volume actually is around 70 milliliters per output. So per stroke of, per heartbeat, the heart is pushing out around 70 mLs of blood, right? So we know that the heart rate is 70, the stroke volume is 70. So we can calculate what the cardiac output of both sides would be. So the thing is these pumps, although they are independent of each other, they're connected. They're very close together, right? We know both pumps are controlled by one SA node. So we know that we can't, let's say one side was pumping more fluid than the other. We can't lower the heart rate of the left side or increase the heart rate of just the left side. We know that if we increase heart rate, it's going to be constant on both ends. So we can't really manipulate the heart rate to equal out fluid balances between these two. But that's where we can manipulate stroke volume, right? So what we can do is we have to make sure that the stroke volume for both pumps are the same. So how do we do that? So again, let's think of an example here. So what if the right heart, let's say our right heart over here, pumped 1 milliliter more per heartbeat than the left heart? Okay, let's say, it's not perfect. Let's say the fluid push isn't perfect, but it's beating 1 more milliliter per heartbeat than the left heart. Well, let's say the heart rate is, 100 beats per minute. So if the heart rate is 100 beats per minute and the right heart is pumping 1 milliliter more per beat, in 1 minute, you will have collected 100 extra milliliters of fluid in the lungs, in the chest, because the left heart isn't pumping that extra milliliter that the right heart is. So it won't be equal. And, after, 10 minutes, you're going to have pretty much like 4.9 milliliters or 4.9 liters or 5 liters here, which wouldn't be good, right? That's pretty much your whole blood volume in your chest, just from pumping 1 extra milliliter of blood forward in the right heart versus the left heart. So we need to somehow regulate that stroke volume. How do we do that? So essentially, the stroke volume, right, is going to be regulated by the venous pressure, right? The venous pressure. Remember, most of our blood sits in the venous system. So this stroke volume, where we can regulate this out, is going to be maintained by the venous pressure. So let's say the right heart is pumping extra then. So if the right heart is pumping more than the left, then you will actually get a higher pressure here. So instead of 25, let's say it's 30 or whatever. So more pressure here is going to lead to less pressure here, right? Because more pressure here is going to pull more of the fluid or use up more of this fluid, the venous reservoir, if you will, and decrease the pressure here. So instead of 7, let's say it's 3. Okay? And then that will cause less pressure here because this pressure of 40 now is pushing against even less resistance. So instead of 40, it will be, 35, which will allow a greater stroke volume from the left heart because it's normally pumping at 120, but since the pressure here is less, we have less afterload, or we have less resistance of previous blood pressure here for the left heart to push against. So that will, in and of itself, increase stroke volume here. So you can see that increasing the stroke volume here indirectly shoots all the way back and increases the stroke volume here. So it quickly does it within seconds, right? If it didn't, we would all be dead. So again, increasing the pressure or the stroke volume, increasing the stroke volume is going to increase the pressure, which will decrease the pressure here because it's using up more fluid, decrease the pressure here, and then decrease the afterload or the pressure that the left heart has to push against, so you can get a larger stroke volume out of the left heart for the same amount of pressure because it's not pushing against anything. Again, think about blowing through a straw versus blowing through a garden hose. It's a lot easier to push a lot of fluid through a garden hose than it is a straw because there's less pressure. I mean, it's bigger, right? Less pressure. So that's kind of how the hearts can regulate that, difference in stroke volume and equalize the flow everywhere um, throughout the body. I think these slides pretty much just say the same things. So a pressure difference between arteries and veins is necessary to drive blood through the small blood vessels and tissues. They must flow at a rate sufficient to supply the tissues with oxygen, of course, nutrients, and remove waste products. Blood pressure usually refers to the arterial pressure, like I said, and it's measured in systolic and diastolic. Um, there is a normal mean arterial pressure, which a lot of people use, especially if you go into intensive care. The mean arterial pressure usually has to stay above 65, and that's a calculation based off the diastolic and the systolic blood pressure. And then the pulse pressure is just the systolic pressure minus the diastolic pressure. Blood pressure is monitored again via baroreceptors or stretch receptors in the brain, carotid sinus, which the carotid sinus is the most important measure of mean arterial pressure, in the neck. So if you've ever heard of carotid massage to decrease heart rate, that's what you're doing there. So actually, let's talk about this a little more. Carotid massage. So our carotid sinus, our baroreceptors, are located on our carotid sinus in the neck. So sometimes when people have a fast heart rate or tachycardia, you can massage those baroreceptors, which will trick them into thinking the blood pressure is higher than it is, which will decrease your heart rate because your heart, it will stop beating as quickly in an attempt to decrease the blood pressure. So, okay, what else? So the aortic arch responds to higher values of mean arterial pressure and pulse pressure, but it's less sensitive than the carotid sinus. The kidney, afferent glomerular arterioles, and the juxtaglomerular apparatus also has baroreceptors. The atria and veins also monitor venous pressure, which I said all before in that little diagram before. Remember that up to 66% of the blood is in the veins or the venous system, which is important for volume or blood volume reservoir. And changes in blood volume changes the venous pressure. So if you give somebody blood products, you will actually just increase the venous pressure, not necessarily the systolic blood pressure that you would take via a cuff. Remember, think of blood flow as a circuit, a closed circuit. I don't know if you guys took physics with Ohm's law, but it's all current voltage is going to be equal to the current, or the output of blood times the resistance, or the afterload. Again, you don't have to know Ohm's law, but if some of you know circuits and things like that, it's similar in a lot of ways. So for pathways in parallel, that's where the brain, kidney, and heart come into play. You increase in resistance or the peripheral vascular resistance will result in a consequent reduction in flow through one organ, can tend to increase the blood pressure and increase flow in others. So let's say you have a heart, lung, or you have a heart, brain, and kidney. If you cut off blood flow to the kidney, if you cut off blood flow to the brain, it'll increase blood flow through all of the other organs that didn't have that vasoconstriction. And a decrease in resistance and consequent increase in blood flow through one organ will tend to lower the blood pressure and decrease flow through others. So if everything vasodilates, everything's going to get a little bit less blood. And unlike the analogous electrical circuit, cardiac output and peripheral vascular resistance are regulated to maintain optimum blood pressure for perfusion of organs. So a blood pressure that's too high is bad, a blood pressure that's too low is bad. Cardiac output is equal to heart rate times the stroke volume, and since the left heart and the right heart are in series, cardiac output must be the same for both pumps, which we essentially regulate by messing with the stroke volume. The heart rate is constant for the left and right side. So again, stroke volume depends on filling pressures, or the preload, and the arterial pressure, that afterload I was talking about. So let's talk a little bit about preload and afterload. So these are two curves here. This one has to do with preload, or venous blood volume coming into the right heart, and this one has to do with afterload, or left heart volume or left heart blood leaving the left heart, right? The stroke volume. Um, and both of these can result in an increase or a decrease in stroke volume. So let's talk about preload first. So increasing preload. So let's say, I don't know, we have 2 preload volume here. We have 2 milliliter, I don't know, 2 units of blood or whatever it is. So let's say we increase that preload. We increase the amount of venous blood entering the right heart. Well, as we increase the amount of blood entering the right heart, you can see that the stroke volume from the right heart steeply increases, right? So even going from, I don't know, 6 to 17, right? You can see a steep increase in stroke volume. So stroke volume can be really well regulated by that right heart, right? By the venous blood from the venous blood reservoir. So if we increase preload or we increase blood entering the right heart from the venous system, we'll get a sharp increase in stroke volume from the right heart, right? And then usually after about 20, it levels off. So it doesn't matter how much more blood you add to the right heart, it won't pump anymore because you're going to get to the point where it's at maximum capacity, right? So that's very important to know, right? If we increase preload, we can increase stroke volume. So what about the right side here? What about when we talk about afterload? Well, afterload has to do with the amount of pressure pushing back against the left heart. So let's say, I don't know, think of a bike pump, right? You start filling up a bike tire. It's pretty easy when you're pumping it until you get to a certain pressure, and then you have to push harder and harder and harder to get even just a little bit of air in that tire, okay? The afterload is increasing. The afterload pushing back against you to put air in the tire is increasing to the point where you can push the thing all the way down. You're only going to get just a little blip of air in that tire now. So you can see that as the afterload increases, as the pressure after the left heart increases, you're going to get a significant decrease in stroke volume. So normally, as the afterload increases, let's say this is 120. Let's say this is 120, and this down here is 200, okay? Systolic pressure. So at 120 blood pressure, your heart does just fine. At 130, good. At 140, it's still good. At 150, your stroke volume's starting to decrease a little bit, but your heart's compensating for it. Okay, as the afterload or that blood pressure goes up, 160, 170, 180, 200, you can see the stroke volume will significantly decrease when the afterload or that pressure pushing back against you increases, right? So it's a thing like, your heart can compensate for that for a while, but what happens is your heart tends to hypertrophy or fail after a while, and you can end up with heart failure if you have elevated blood pressure for a long time, because your heart has to constantly push against that, grow the muscle, which will leave less room for blood to actually be in the heart, which will also decrease your stroke volume. So a healthy heart can do it pretty easily, but over time it will decompensate, and you'll get increased heart muscle or hypertrophy. The key thing, again, is that the venous volume will regulate the stroke volume, mainly, right? That afterload will have a little bit of an effect on it as well. And think of like epinephrine and norepinephrine, right? Things we already learned about. Well, these can activate beta receptors in the heart, right? And increase contractility, which can increase stroke volume from a different method, from sympathetic input. But again, constant epinephrine and norepinephrine activation of the heart will cause the heart to decompensate over time too. So your body tends to compensate for things for a while and then decompensate. So let's think about how. So, and we already talked about this a little bit. What if the stroke volume for the right heart is greater than the stroke volume for the left heart, right? Well, you're going to get an increase in pressure here. It's going to decrease pressure here, and decrease the afterload, which will allow the left heart to push more stroke volume against the arteries here, because essentially you're decreasing from 120 to even less, which will increase the amount of stroke volume you'll have available to push out of the heart, right? So, if in a normal heart, if the output from the right heart exceeds that of the left heart, it will have two effects. The pressure in the pulmonary vein will increase, i.e., the preload on the left heart will increase, and the left cardiac output will increase. Pressure in the vena cava will fall, or the venous reservoir, right? i.e., the preload for the right heart will decrease, and the right cardiac output will decrease. So this will continue until the outputs and stroke volumes of the two pumps are equal, right? Until they are equal, thus resulting in consistent and equal flows of blood throughout the entire body. So let's talk about what happens when there are problems, right? Well, I talked about heart failure, right? What is heart failure? Well, there's two types of heart failure: systolic and diastolic. Systolic heart failure has to do when your heart just gets worn out and it dilates and it doesn't have the squeezing power it once did. It's very flappy, not strong. And then there's also diastolic heart failure, where your heart has been working hard for so long that it hypertrophies. So instead of fitting 70 mLs of fluid in that part of the heart, right? Instead of fitting 70, because it hypertrophies, it pushes into the atria and ventricle, and now you can only fit 50 or 30 milliliters instead of the entire amount that you need. Both cases end up in a significant decrease in stroke volume, right? So we looked at the normal heart here. This was stroke volume on here, and this was the preload and afterload. Well, this is the same. Stroke volume to preload and afterload curves here, but you can see that in patients that have a significant decrease in stroke volume, either from diastolic or systolic heart failure, you can see that compared to a normal heart, congestive heart failure hearts are much weaker and cannot produce the amount of stroke volume that a normal heart can. So our hearts don't push as much forward. So what happens? What does the heart do? Well, the heart does what it always does. It increases the preload, and you can see the increase in preload does have an effect of increasing stroke volume up to a certain point. It will never get to the same level as a normal heart will. And the problem is once you get past a certain preload, you'll end up with congestive symptoms where fluid kind of sits still, doesn't go forward, doesn't go backwards, starts to accumulate like we talked about earlier if your heart were to pump 1 ml more than the left heart and vice versa. The same thing here in patients with hypertension or heart failure or whatever it is. You can see that in the afterload, or as the pressure increases, even within a normal pressure. So let's say this is 120 again, and then this is 150, right? You can see that even when patients aren't hypertensive, like 130, there's been a significant drop-off in stroke volume. And you can see after we get about 150 and keep going, the stroke volume is going to be cut very significantly. So on the left heart, the stroke volume can be significantly worsened by an increase in systolic blood pressure. And then on the right heart, the stroke volume can be significantly decreased and worsened when you add more preload. You can get congestive symptoms, right? So again, with heart failure, stroke volume, a fluid balance or a fluid war definitely becomes very important and very significant when you're managing these patients with antihypertensive or beta blockers or cardiovascular drugs, right? So there's some cardiovascular problems that can occur. We have, left heart failure, right heart failure, orthostatic hypotension, pulmonary artery hypertension. Let's talk about pulmonary artery hypertension first. So what does that mean? Pulmonary artery hypertension is a disease in which is a disease of the lungs. So what happens is patients who smoke or have significant pulmonary fibrosis of the lungs or lung tissues, this will decrease the lung's ability to push blood through it. So think about this. In patients with emphysema, what happens is their lungs expand. They dilate out. They're huge, very big lungs. And those big lungs and the big alveoli, although they don't work very well, they damage the blood vessels and they compress against the blood vessels. So you need more pressure against those blood vessels just to get the blood through the lungs back to the heart. So what's our body do? Well, it increases the pulmonary artery pressure to be able to do that. And you end up with pulmonary artery hypertension. Your right heart really isn't meant to push a lot of pressure. 25 is where it should be. But if it's pushing 40 millimeters of mercury of pressure just to get blood through the lungs, then what will happen is you can end up with right-sided heart failure, where the heart either hypertrophies and doesn't fit as much fluid in it, or it dilates and is really flappy and can't push fluid forward. Both circumstances will end up with an accumulation of fluid behind that pump because it's not pushing things forward. So the only other direction it has to go is backward, right? So you get blood kind of building up in the peripheral areas, right? You get what's called peripheral edema. Blood, the venous system has like no pressure in it. So gravity is going to accumulate all the fluid either in the GI tract or the legs. And that's why patients with right-sided heart failure have peripheral edema, right? Same thing with just right heart failure in general, even in the absence of pulmonary artery hypertension. Any time you get right-sided heart failure, you're going to get fluid back up in the periphery. What about left-sided heart failure? So let's say we have hypertension for a long time, and instead of 120, we have 200. Well, that's going to cause this side to either dilate or hypertrophy. Either circumstances are going to end up backing up blood behind it, right? And you'll get blood back up in the lungs. You get congestive heart failure, where the lungs become full of fluid, which can then lead to right heart failure because now the right heart has to keep pushing against this. The left heart can't push this forward, and you end up with pulmonary congestion, right? Significant respiratory failure from that, right? It's like drowning essentially. You're drowning in your own fluid. And in orthostatic hypotension, which is a condition where the blood pressure drops when you go from laying to standing. Maybe we've all felt that a little bit when you stand up too quickly and you start to feel a little bit woozy. So remember, the brain is at the top of our body. Gravity always likes to pull things down. Now we know that the brain has its own baroreceptor, but maybe the system isn't working the way it should. But how does the system work when it should work, right? So when we're lying down, everything's fine, right? Blood doesn't really have to fight against gravity to get it to the brain. But when you stand, blood is going to be pulled down, and the brain can then be starved of oxygen. And if you starve the brain of oxygen even for like 3 seconds, you'll start blacking out. You get that tunnel vision. You might lose your hearing. But a way to regulate that is by increasing the preload, right? Increasing the preload via alpha-1 vasoconstriction on the brains via the sympathetic nervous system, which is a quick reflex, right? When we stand up quickly, our sympathetic nervous system realizes that drop in blood pressure will vasoconstrict the venous system, increasing the preload to the right heart to increase the stroke volume in the overall systemic circulation once it makes it to the left heart, and increase the blood pressure so we don't pass out. Patients with diabetes, where their nerves or their sympathetic or they have autonomic dysregulation, tend to have orthostasis because their sympathetic nervous system is more or less shot. So they can, you have to tell them to stand up slowly. So what happens if we were to give a patient an alpha-1 agonist? So alpha-1 vasoconstriction will increase preload. Well, if we give somebody an alpha-1 antagonist, one of the biggest side effects is orthostasis or orthostatic hypotension as a major side effect for this very reason. It blocks the sympathetic nervous system's intrinsic ability to vasoconstrict the venous system to increase preload and increase blood pressure. Okay, so this is already what I said. So let's talk about the most common disease. Hypertension. Hypertension, I have hypertension, probably from stress, maybe. and salt. I like salt too, and potato chips and things like that. So it's the most common disease. So what can happen in blood pressure? Well, instead of 120, maybe we have 170. So what happens when our blood pressure is too high? Our heart is beating and making a pressure that is just too high. Well, the blood pressure can go through our brain, our heart, our kidneys, our muscles, our organs, and cause damage to those organs, right? And also the heart is working harder to push that pressure. He brought me a toy and he's just breathing at me. So our heart has to push harder against that, and eventually it can either become dilated or systolic failure, or it can become hypertrophied or diastolic failure. Either way, it's going to end up in a heart failure situation. So again, hypertension will promote vascular disease in the heart, brain, and kidneys, all in other places, can lead to atherosclerotic plaques, which can rupture, exposing collagen and causing platelet aggregation and block of blood flow. If it's in the brain, it's a stroke. If it's in the heart, it's a myocardial infarction, things like that. If it's in the periphery, it's just whatever muscle or organ it's damaged. It can lead to coronary artery disease. Again, if it's in the heart, which can lead to an acute coronary syndrome, which is that rupture of the plaque in a coronary vessel, leading to a myocardial infarction or damage of the heart muscle, which will lead to heart failure. And if it's in where the SA or the AV node is, it can lead to arrhythmias, be it fatal or non-fatal arrhythmias. So this is a diagram that kind of shows all of this put together in the generation of blood pressure. So we know cardiac output, and this looks like Ohm's law here. The output is going to be, the total blood pressure is going to be proportional to the cardiac output times the resistance of that output. That peripheral vascular resistance is going to be due to arterial blood pressure afterload, right? The afterload. And the cardiac output is going to be directly dependent on the heart rate, which is constant, and our stroke volume, which has to do with the venous system or the preload, as well as the contractility of the heart, which can be changed with sympathetic or parasympathetic activation. And remember, our preload is going to have to be due to the venous blood reservoir and the blood volume in general. Okay, which this all I just said all of that here. So when we think about orthostasis again, let's think about orthostasis, or a drop in blood pressure. Our body has two mechanisms by which it regulates blood pressure to increase or decrease it over time, right? There's a short-term control blood pressure, something that needs to happen really, really quick, and then some longer-term regulation of blood pressure, right? So the short-term controlled blood pressure. So let's say you stand up quickly. You wake up in the morning, you stand up quickly, and your body recognizes that there was a drop in blood pressure because you went from being horizontal to vertical. So what's the intrinsic quick regulation to increase your blood pressure? Well, it's going to be an increase of heart rate, as well as increase in blood pressure, which will keep you conscious, right? So we have a couple of things here, right? We have our heart, we have our brain, we have our arteries, and we have our venous system, right? So quickly, when you stand up quickly, the brain is going to recognize, oh shoot, we have a low blood pressure, lower than normal because we went from being horizontal to vertical. What's it going to do? Well, it's going to cause beta 1 sympathetic activation on the heart to increase heart rate and contractility, which will be its major role as far as the heart. And also it will inhibit the muscarinic parasympathetic activation on the heart, which acts to decrease heart rate and contractility, right? So the overall effect is increased heart rate and contractility. Well, it's also going to have alpha-1 vasoconstriction via the sympathetic nervous system on our arterioles to increase the peripheral vascular resistance, which will increase blood pressure, right? It's also going to have alpha-1 mediated vasoconstriction on venous tone to push that blood reservoir in our venous system up to the right heart and increase preload to increase stroke volume. All of this is going to increase stroke volume and cardiac output as well as elevate blood pressure. So that's how our brain and our body is going to cause an increase in blood pressure and heart rate when you stand up quickly. This occurs within seconds, right? This is why you don't pass out every single time you stand up. Now, with patients that are dehydrated, they're usually, they can have orthostatic hypotension because their blood volume is just not there, right? They don't have that blood volume reservoir in their venous system to be able to increase preload and things like that. So how does all of this sympathetic activation and all of this occur? Or how is it sensed? How does your brain sense that, I mean? Well, it senses it via those baroreceptors, right? That's how it happens quickly. They're very sensitive. They're only good for short-term control. And I mean this because they're sensitive, right? So they're sensitive. They'll be able to even sense a very small change in blood pressure. However, if you increase a blood pressure, I don't know, from 120 to 170, and you keep it at 170 for a day, those baroreceptors will reset thinking that 170 is a normal blood pressure. So again, it's not good for long-term control, just good for short-term control as needed, right? So what about the long term then? We know the short term now. Long term, how do we regulate blood pressure? Well, that's really only regulated by the kidney, okay? None of the other things, all of the other things really are short term, right? But the kidney is what regulates the long term. Low blood pressure will stimulate the kidney to make renin, which will lead to angiotensin production from angiotensinogen and aldosterone production, which will increase blood volume by increasing the amount of sodium and water reabsorption in exchange for potassium, which will increase the blood volume and increase preload. Okay, and that's one of the problems with heart failure, right? With heart failure, our blood pressure tends to decrease, right? Our stroke volume is not being able to maintain a blood pressure that's really, really high or high enough to even be normal. So what happens is our kidney reads that low blood pressure. It doesn't know that the heart's having an issue. All it senses is low blood pressure. So what happens is it's like, oh no, we have a low blood pressure. As far as I know, the heart's okay. Don't really talk to the heart. But let's go ahead and increase water and sodium reabsorption, which will increase the preload, and then the heart will take care of the rest, right? No. What happens is you increase preload, yes, in a very short-term thing. That increase in blood volume from the kidney will increase preload, which will increase stroke volume. But again, the heart's weak. It will decompensate and either lead to vascular congestion in the chest or peripheral edema in the legs, which you'll see these patients, they'll be what are called volume overloaded, and you need to diurese them with diuretics to make them pee out all their fluid because their kidney just doesn't know. That's why all of our heart failure patients have water on their legs or in their lungs or volume overload. That's why all of them are required to be on a diuretic. Any patient with heart failure has to be on a diuretic or an ACE inhibitor. They should be, at least. But you'll learn that in ClinMed and when we talk about that here in a couple lectures. Okay, so let's say we want to manipulate blood pressure. So what medications will we use to be able to manipulate blood pressure? Well, there's a couple of different classes, right? We know that the mean arterial pressure has to do with cardiac output and peripheral vascular resistance, right? It says it right here. So we can mess with blood pressure either by messing with cardiac output or the peripheral vascular resistance. So cardiac output has to do with the heart, right? So we can use beta blockers, beta 1 blockers, to decrease sympathetic beta 1 activation and decrease heart rate and contractility, which will decrease blood pressure. We can use calcium channel blockers. Calcium is very important in the contractility and the contraction cycle of the heart. So if we block calcium channels, yeah, it makes sense that will decrease heart rate and contractility. In the peripheral our arteries, how do we decrease peripheral vascular resistance? Well, we can use alpha-1 blockers to decrease sympathetic mediated alpha-1 vasoconstriction. We can use calcium channel blockers, right? Calcium channel blocker, remember calcium depends on smooth muscle contraction depends on calcium influx. So if we block calcium channels, we'll vasodilate. We'll use angiotensin converting enzyme inhibitors and angiotensin receptor blockers, which we haven't really talked about much yet, but we will talk about. All of these are considered vasodilators, right? ACEs and ARBs, calcium channel blockers, alpha blockers, are vasodilators because it will increase or decrease sympathetic vasoconstriction, so they'll vasodilate. Same thing here, we can use alpha blockers on the venous system, organic nitrates. Now remember, nitric oxide was a very important vasodilator that we talked about. It elevates cyclic adenosine monophosphate, which will cause vasodilation, nitric oxide. So we can use organic nitrates like nitroglycerin. For blood volume, we can use beta blockers. There are beta-1 receptors in the kidney which stimulate the release of renin. So if we block that beta-1 stimulation release of renin, we can decrease blood volume, which will decrease that preload. It will, decrease that venous reservoir, right? And ACEs and ARBs as well will stop angiotensin and aldosterone from the kidney. And diuretics, or things that make you pee, will make you pee out your blood volume. So you'll end up with an overall decrease in blood volume and decrease in blood pressure. So this is where all of these classes come into play on how they decrease heart rate and blood pressure and peripheral vascular resistance and all of that. And some of these, we use medications from each of these to regulate the people's blood pressures. Okay, so that pretty much has to do with the introduction to cardiovascular drugs. Now we'll start with the other ones.